Oh, no, no, I'm just trying to make sure nobody's, that's 9 feet tall, sits in front of the camera. Hello.
I'm lecturing right now.
Oh, very good.
Are you in charge?
I am not in charge. I am the one going to Google Drive. I can certainly take you up there and find you the person.
I don't know if they already have my thing.
I, you head to the podium and I'll send someone up.
Ladies and gentlemen, please come in, take your seats. Harold, we're now ready to start again. And then those of you in the back, please be quiet. And again, we want you to hurry up, take your seats. We do want to get started. Ladies and gentlemen, welcome back. Cancer Control Society, 42nd Annual Convention, Labor Day weekend 2014. And one of the privileges of being able to work with the Cancer Control Society and Lorraine Rosenthal is we get to go to conferences around the country, occasionally get outside the country, but we get to meet not only fascinating, interesting people, but we find speakers. And our next speaker is one of those. And again, its topic is going to be skin. And in fact, skin health, skin lesions, skin cancer. A lot of that in the news. Most of what is in the area of media is either not true or only half true. Dr. Anil Kalhoran, or Dr. T, for those that know him, is both a medical doctor and a chiropractor. And we will read the biography to learn a lot more about him. And for our purpose today, we're just very happy to have Dr. T with us. Thank you for being here.
So we're talking about skin cancer. People like to think that their skin is separate from the rest of their body. People believe that if they just treat the skin, everything will be fine. To me, the more important thing is what causes disease in general in the skin, what makes the skin age prematurely, as well as what leads to the gradual evolution of cancer in the skin and elsewhere in the body. The skin is a crucial organ that is often neglected. People think of it in terms of cosmetics, generally, but they forget that the skin is the most important barrier organ that we have. It protects us from the environment. It has a crucial immune system within it. The circulation and the lymphatics and the basal membrane of the skin are crucial for our overall health. And only recently, new science has started coming out, showing us that what we once thought was not true. It is not as simple as we would like to believe. And we have a tendency as human beings to oversimplify things. We tend to want to make sure that we have something to point a finger at and blame for all of our disorders, sufferings, pains, diseases, and wars. We like to blame the sun, for example, for everything we have with our skin. Or we like to blame genetics. Or we like to just blame simple old age, none of which are true. There could be a genetic susceptibility, that is true. If you are overexposed to the sun, you are creating free radical damage in the skin, that is true. But these are not the most important things in maintaining skin health, skin longevity, and prevention of skin cancer. I have been, for many years, working with the skin, not because it's the only organ of choice, but because it was a method for me to quickly help people who suffer with different types of skin lesions, molds, protrudences, other types of growth, as well as precancerous lesions, in a very easy method that simply peels off the offensive lesion and gets rid of it within a few minutes with no pain, no surgery, no medical intervention, no invasiveness, and with superior results. Very little to no scarring at all, as you shall see. Therefore, because of the increasing demand for this type of service, I had to delve deeper into understanding the skin processes and the skin's disease evolution in order to be able to give people the advice they need to prevent premature aging of the skin. Most of it has to do with the diet, with lifestyle, with activities, with exposures, and not just to the sun. And people need to know that if they want to have a healthy skin that looks beautiful, that looks radiant for many years to come, that defies the ravages of aging. I also believe that if we succeed in our quest to help people, we want to give something back. And that is even more important for our health sometimes than taking care of ourselves. We need to take care of others as well, and that's why all the proceeds from the skin lesion clinics around the country that are conducted by myself and by the doctors, physicians that I have trained in different states who work with my method, they all are considered their charity days, because that's how they support the non-profit activities in the United States, in Nepal, and in other locations, saving children from childhood trafficking, prostitution, and slavery, and also gaining information through research that helps us improve the health of children in the United States and in the West. So, before we get into the science of the skin and skin lesions and cancer, I just want to also invite you to join us in some of our humanitarian work in Nepal. You're welcome to come and to see for yourself what is being done. You can help yourself. You can join one of our treks. Right now we have 10,000 children and growing in Nepal, and this is all supported by our skin lesion clinics. So people who used to be very moly are becoming increasingly holy. And when we come to Nepal, we engage in trekking activities, and some sightseeing and culture, but most of all, we connect with the children and their caretakers in Nepal, in authentic villages. It is truly a unique experience that is life-changing for most people who join us. The next group is going in October, the one after that in March, and there are still places in our groups for you to join. So you'll be invited to do that and see the Himalayas as well, in a way that very few people get to experience Nepal. And you'll be surprised at how healthy the skin is with those children and those adults that take care of them, I rarely see skin cancer in Nepal. Even if they have all the reasons to develop cancer, they have the abnormal lesions, they have the dysplastic nevi, they have the birthmarks that sometimes you're born with, some of those things that increase the risk of skin cancer, that they do not develop the cancer itself. And we have to ask ourselves, why is it that they don't and we do? Why is it that between 100 and 200,000 Americans are diagnosed with melanoma every year? Why is it that almost 3 million Americans are diagnosed with basal cell carcinoma and close to 1 million with squamous cell carcinoma every year? Why is it that skin cancer is the most prevalent of all cancer? And in fact, if you take all the most famous cancers, lung cancer, breast cancer, colon cancer, prostate cancer, and combine them all together, you will still not have the number that it takes to get to the amount of skin cancer that we have in our society. So we have to look to the skin to get some answers. And for that we need to look into the new science that looks at the skin as a vital organ with a so-called dead epidermis, a so-called live epidermis, and the dermis. Those are the three crucial layers of the skin. We come in touch with the dead epidermis, but it is not truly dead, because it is crucial for our life, because it has within it all those special oils that we secrete, and those oils have natural antimicrobial effects. And those oils get destroyed so easily when we take a shower, when we put soap over our body. They get destroyed so easily when we put lotion all over our body with high content of oil, because we change the concentrations of the different types of oils that are on our skin that are antifungal, antiviral, antibacterial. We have those important immune cells of the skin that are continuously being challenged by our polluted environment and by the microbes that are able to grow as a result of our neglect. And what is our neglect? Taking too many showers. When you take too many showers, you neglect your health. Surprising, huh? When you use soap all the time over your body, you destroy the microbiome of your skin, the healthy bacteria of your skin, which are directly connected with the healthy bacteria in your colon, in your gut. We all know about the probiotics, but have you thought for a minute about sustaining the probiotics of your skin, which are no less important? People forget what they don't know is not blissful ignorance. And we end up burning in the sun instead of staying in the sun. We have to expose ourselves to the sun regularly every day because we need vitamin D, or we need the supplementation. Over 80% of Americans have insufficient levels of vitamin D, and if you look at optimal levels, it's way over 90%. Vitamin D protects us from skin cancer. And people who are continuously avoiding sun exposure and become weekend warriors, people who burn once every 6 months, instead of having incremental exposure to the sun every day, a little bit, just enough to get slightly red. That's how you make the most vitamin D in the skin where it counts, and that saves you from the skin cancer, which oral vitamin D is not as powerful to give that service, because how much of that oral vitamin D ends up on the skin? So you do need some skin exposure to the sun, but on a regular basis. However, if you get too much UVA, which most of us do because we live behind closed doors and we are exposed to the sun, through what? Through windows. That's how we get a higher risk of skin cancer. We need the real direct sun exposure. And today we are exposed to fluorescent lights. Fluorescent bulbs emit exactly the wavelengths, spectra of UV that are incriminated with regard to skin cancer. How many of you are continuously exposed to fluorescent bulbs? Energy efficient indeed, but cancer efficient as well. We have other problems with our lifestyle today that explain the difference between the health of Nepali people's skin and ours. They walk a lot, they move every day, they walk 2 hours back and forth just to go to school or to teach. How much movement do we have? That improves the circulation dramatically, improving the immune factors' availability to the skin surface. Also, they don't use continuously and obsessively the same antimicrobial product that we use. And I'm not talking just about natural soap here. I'm talking about all those toxic chemicals that people use. Alcohol is just one of them. But there are so many antimicrobial creams today that people are using all the time. Every second they enjoy a hotel room, they immediately kill everything in sight. And every time they feel like they touch something, they immediately use potent antimicrobial toxins that create microbial resistance. And all the new resistant microorganisms that are killing people in hospitals today are resulting from excessive hygiene, excessive germophobia, which we are all suffering from because of brainwashing. So we allow new microbes that we never had to deal with to cause inflammation and immune suppression in our skin, increasing our risk for skin cancer of all types. Enough reasons why modern society has this skin cancer. But no, the worst is our food. Anything that increases inflammation in the skin is going to increase the risk of cancer in the skin. Cancer develops from an inflammatory response. And as soon as you eat foods rich with pro-inflammatory molecules, molecules that lead to inflammation in other words, that's when you increase the risk of all types of cancers, but especially the ones that depend on the integrity of your fatty layers. The skin, similar to other parts of the body that requires flexibility, which we see in the lungs and in the blood vessels. We need flexibility. We need elasticity. For that, we need to keep the integrity of the elastin and collagen, which prevents premature aging. But that means that we also have certain types of lipids or fats, fatty acids, that are supposed to be incorporated into the structure to keep their flexibility. And they get destroyed whenever we eat foods rich in fat, especially if the fat has been exposed to high heat, because then we end up attaching the fats to sugar. It's called glycation. When we glycate our fats, they become a major source of inflammation. But that's nothing by comparison to what happens to our skin when we glycate our proteins. And when we eat a lot of proteins, we have already a lot of free radical damage. But if those come together with fat, and if our blood sugar is slightly elevated, and if we are also exposed to fructose, as in high fructose corn syrup, or maple syrup, or excessive amounts of honey, or agave nectar, all of which are extremely rich in fructose. When we do that, we cause glycation in large amounts. And that is a major source of aging of the skin because it makes the skin turn to leather. That's how you make leather, by increasing its exposure to heat. Taking healthy, nice skin and turning it into leather requires free radicals and heat, similar to what we have in our body when we eat foods rich in AGEs, advanced glycation end products. AGEs are probably the #1 source of inflammation in the body. So when you eat foods high in arachidonic acids, which is pro-inflammatory, which are present only in animal products, by the way, and in dairy products. So if you eat a lot of animal products, a lot of dairy products, as you only do in Western society, you increase not just the inflammatory molecules, you also increase the AGEs, because show me how many people are eating their meat raw. Most people are cooking it at a temperature higher than 248 degrees Fahrenheit, which is the exact temperature above which AGEs start forming. Almost everything you do to flesh and also to grains and to legumes that turn them into beautiful golden brown, attractive to the palate, highly addictive in fact. As soon as we eat those types of food on a regular basis, we dramatically increase our AGE intake. And that's in addition to the AGE that we manufacture inside our body. That inflammatory process, together with eating rancid fats, will directly contribute to free radical damage. And if you go to YouTube or if you go to our website and ask for some of those lectures, you can listen to them and then you'll know where you're getting rancid fat. You'll know where you're getting AGE. Those are the things that make the skin age prematurely and at the same time increase its risk to cancer, because the scientific studies have been clear. When the skin ages prematurely, it also becomes susceptible to cancer 5 times, 10 times, and 20 times worse than skin that retains its youthful elasticity and its content of water. So when we talk about skin science, we need something to evaluate how the skin functions. What is the elasticity of the skin? Have you until today heard of a measurement, a test that is objective, that will tell you if the dermis retains enough elasticity, which means that it is also useful and also not damaged by AGEs and inflammation? There is such a device, and you have it right here in the picture. One of these 3 devices measures the elasticity of your skin scientifically. It has never been available to clinicians until today. It's only been used in big research facilities in universities where people study the skin but don't connect it to clinical practice. Now it's available for the first time. The other machine on this trio measures the integrity of the skin barrier, which is crucial for your life. Because when the barrier is disintegrated, your health degenerates. Your body becomes diseased and cancer can start. And your skin is your best line of defense against the environment. I prefer that the skin will be the one to develop a cancer instead of my liver or lungs or kidneys or other crucial organs. I prefer that most cancers will occur within the skin, because then we can easily treat it, as you shall see in a minute. We can eliminate it, even in its early phase. We don't have to wait for it to become dangerous. We don't have to keep monitoring it until it's too late, until there's panic, until we have to rush into biopsy. And you already know that, if you are holistic-minded, that the scientific literature implicates the biopsy with spreading of cancer. when you cut through a cancerous lesion, if you waited that long for it to get that far, you are dramatically increasing the risk of spread of the cancer because you introduce the cancerous cell into the circulation. At the same time, if it is not yet cancerous but looks suspicious, even if it is benign, it's already starting to change. The cells are already becoming atypical. And in that situation, when you cut into it, when you do the biopsy, you increase the inflammatory reaction within the lesion, which increases the risk that in the future it will become cancer, even if today it was not. So the biopsy is not the best way, and it only accompanies the excessive weight. That weight watch approach, that monitoring approach is not logical because it makes the lesions increasingly dangerous over time until the doctor will no longer be able to say, let's leave it alone. Let's avoid stimulating it. But once we see a dangerous lesion, is that a good time to stimulate it? Obviously not. So it is a very illogical approach that we are taking with regards to skin cancer today. It's better to start using those devices and finding out if you have lost the integrity of the skin barrier, if you have lost the elasticity, and the third instrument tells us if you have lost the water content of the deeper epidermis, where you should have water, while in the dead epidermis you should have almost no water at all, mostly fat. And that's how we discover not just about your skin health, but about the health of your entire body, because the skin represents every other organ in your body. So this is the best way to avoid any kind of biopsy to find out about the overall health. You simply measure the skin without doing anything dramatic. So, when we look at simple, innocent skin lesions, like the little dark area that is within this melanoma, you see that little circle that I'm encircling with the arrow? This is how it started. So if you have a tiny lesion like this that is dark and small, you think it's nothing, you think it's innocent. But in reality, this is where the melanoma started, until finally it became this whole thing. And this is true here. You see that innocent-looking, dark, small lesion that you have here? It could be tiny. It could be just 1 or 2 millimeters in diameter. But that's where the cancer starts, and the melanoma develops until it becomes this big. It's been allowed to grow for years and years. Wouldn't it be nice if you could just get rid of those melanomas by simply eliminating the tiny lesions at the early phase, when you have a way to do it with no surgery, with no pain, and with no side effects, and with minimal to no scarring? That's when you should get rid of it, and you could easily do it with numerous types of skin. Even skin cancer like a carcinoma that can evolve into an advanced volcano like this one can easily be treated because this type of skin cancer never goes below the basal layer. So you can easily become a beautiful result like you're seeing here, the after of this patient named Arthur, who can barely see that he had a major cancer on his forehead. It was so simple to take care of it by simply eliminating the cancer to the basal layer instead of digging very deep with your knife. Even when a person has birthmarks have a significantly increased risk for developing melanomas or other types of cancer within them. So this little girl, this is already her second treatment. On her first treatment, this whole area was a hairy, large birthmark. Now you can see how beautiful this area here is that's been treated. And here, she had a deeper root to the lesion. So in the second treatment, we eliminate that root. And then everything looks like this. And it's very nice. I'm almost done, almost done. This is another cancer that somebody plucked at. It was very deep. After the treatment, it becomes white immediately, and you can see the depth of that lesion. It's almost the size of a dime. And after a few weeks, it's already closed off and it's almost finished the healing process. Within another month or two, this redness will disappear. And here's a farmer who has a lot of lesions, because farmers and other people who burn their skin too much could have 30, 40, 50, and sometimes 100 basal cell carcinomas. This person has already been surgery. Was a second nature to him, and he got tired of all the surgeries because the cancer always came back. So this is how many treatments you can do in just one sitting. And here's an example of a before and after, how effective the treatment was in eliminating these cancers that you see on the left side. And you see here that it's completely healed. Now we just need to clean up and blend it into the surrounding tissue, so it will not be visible anymore. Here's a very important cancer that was biopsied. This patient did not want to have a surgery that would destroy and disfigure her, so she waited for a few years with this cancer. And this on the right side is after the treatment. And now you see the results. When the treatment is finished, you can barely see she had anything there. That was a deep cancer. This is squamous cell carcinoma after one treatment. On the left side, you see that nothing much is left. It used to be all this whole area right here. Very little bit is left, only a few dark spots, so we take care of them now and they will be finished. And this is another squamous cell carcinoma. On the left side is the initial treatment. On the right side you see that nothing of it is left except for a few little dots. Same thing left and right. And here is a type of a sebaceous tumor called nevus sebaceous. It can easily become cancerous. There is very few. It's very rare, but there are almost no successful medical treatments for that. But with this approach, it almost completely disappears. You can eliminate the risk of cancer. Here's a person who treated himself with an online product. You see what happened to his nose? It was eaten up because he kept treating himself, thinking that he was eliminating his cancer. Instead, he eliminated most of his nose. And you see that on the side, he still had some cancer that had to be treated in one of my clinics. But there are other lesions that can be removed. You know, this tongue tumor and this lip tumor are just a small example how they could easily be treated. And here it is. That's my last slide. So if you want to move it. Well, I had a beautiful slide showing how this tumor here completely disappeared, how this tumor here completely disappeared. And for some reason, this slide presentation got cut short. But it's okay. There are many other types of lesions that I want to show you, a couple of them that touch the eyeball, that are between your eyelashes, that in the nooks and crannies of the body, that are in mucous membranes, not just in the mouth, but other mucous membranes that can easily be removed with no surgery, no pain, no scars. With great ease, you can remove hundreds of lesions in one sitting if you choose to. All the proceeds support the nonprofits. It's very reasonable, and it can truly protect 100,000 out of 100,000 people from ever developing melanoma, which is life-threatening. You can so easily prevent people from the damage of surgery, the damage of the scarring and disfigurement, and the higher recurrence rate of cancer with people who do the surgical approach. It's better to prevent, to look at your whole body and eliminate every little dark spot that could one day become melanoma, to eliminate every rough area, every red area, scabby, sloppy area that could one day become cancer. Eliminate it.
Appreciate the presentation. Thank you very much. And actually, one of the most difficult things my job is up here is in the middle of a very excellent presentation, have to tell the speaker that we're out of time because we do obviously have to move along. And Dr. Cohen, are you going to be around today? Talk to you.
So you probably wrote down the website information. There are clinics in the LA area on Monday and on Tuesday. And there is a doctor that I've trained who is local to the area and who will be providing those skin clinics once a month in a few spots in Los Angeles, so you'll be able to enjoy that. Just go on the website, ecopolitanskinclinics.com, and you'll see the different. Yeah, here you have it. Oh, that was it.
And go online to cancercontrolsociety.com. Look in the biographies for Dr. T's contact information. Thank you very much. Again, ladies and gentlemen, once again, those patients that are going to make a presentation at 3:30, pick up your green card, fill it out. The white card will give you a few pointers on that. You will line up on the right side of the room before 3:30 so that we can do it by law. And again, please keep your comments, your testimony short and sweet. Primarily want to know who you are, what the disease is, any conventional treatment, then obviously what you treated it on the integrated and alternative side. And usually we do have quite a few, so that's why we ask you to keep it down to about a minute and a half, and then let the people know where you're going to be. That's great. Because in most cases, the patients will either go to one of the booths, or they will be around the foyer area so that you can talk to them. Harold, we need to move along. Ladies and gentlemen, certainly we welcome you to the 42nd Annual Cancer Control Society Convention, Labor Day weekend 2014 at the Sheraton Universal City. Our next guest is Dr. Ben Johnson, a medical doctor and hospital man. So he has it's a dual degree. There's some certain similarities, and then there's obviously some unique items. Again, please read the information in the biographies. Started with his foundation in psychology, which has led to many of the wonderful things that we've heard him say. Blended that medical things in demography and some of the other elements of complementary medicine. Dr. Johnson, happy to have you here again.
Thank you so much, as always. It's wonderful to be here. Thank you, Frank. Thank you, Lorraine. Distinguished guests and you of the audience, you are why we're here. And without you, all of the distinguished speakers would have no validity here. Dr. Adele, thank you so much for that talk. So many wonderful speakers here later in the day will be Ed Griffin, been a hero of mine for decades. He'll be speaking this afternoon. Following me, don't leave, because I will be helping you understand the least utilized medical detection technology today. After me, Dr. Cyrus Radley will be sharing with you the most underutilized treatment modality. So be sure to stick around for that. Distinguished guest, I wanted to introduce a few people. Annie Brandt, would you stand up? Best answer for cancer, amazing lady. Dr. Delina McGalco, right here in our own LA, almost not from thermal imaging out there and helping people learn how to do that as a business. She's amazing. So thank you so much. And thank you, the audience, for being here. Now let's make sure that I know how to operate this probably simply arrow downs. So let's talk about testing. I'm specifically going to talk about thermography and ultrasonography today because they are highly underutilized for breast imaging. Both of these tests can be used for imaging the whole body. For instance, ultrasound, you can look at the thyroid, the carotids, breast, and the abdomen. You can see the pancreas, spleen, gallbladder, kidneys, adrenals, and then low pelvis, the uterus, prostate, bladder, testicles, ovaries. So you can use these tests for many means. And thermography, you can do physiological testing, looking at everything from breast to dental disease to muscle disease, nerve disease to dysbiosis of the bowel. So they're both amazing tests, but we're going to kind of look in today and limit that to breast and the imaging of breast today and where they fit in that. So there are different type tests. Thermography is a test of physiology. It's not looking at anatomy, so regular doctors just aren't used to seeing physiology. They're used to looking at physiological aspects. They're used to looking at anatomy. So don't expect your local family doc or radiologist to have a clue because that's not what they're used to looking at. So the test of anatomy are ultrasound, MRI, and mammography. I will talk more of those a little bit. So ultrasonography, let's talk about that a little bit first. So this is the type of probe that you would look at. The transducer, use a little gel as an interface from the transducer to the skin. And so what is ultrasound? A transducer is used to send ultrasonic sound waves into the tissue. These waves bounce off of different tissues and then are sensed by sensors in the head of the transducer, sent back to a screen and interpreted into an image so that we can see it. That's a simple way to look at it. Ultrasonography is very, very good for breast examination. Sensitivity is around 74% according to the latest article that I can read. Specificity is up near 90%. Maybe more importantly, there's no harmful x-rays. There's no radiation, so this is not going to give you cancer. You can repeat this test as often as you want. So here's what some ultrasound pictures look like. So this would be a fluid-filled sac. This would be a solid tumor. You can see the density inside of the outline structure. And this is fluid and this is solid. So this is a mix. So this is what a ultrasonographer is looking at in the breast imaging, and then the doctor interprets this as to what he perceives might or might not be there. Here are the famous calcium plaques that are frequently talked about in the mammograms. Calcium spicules there. Here are the calcium deposits, as you can see in this pocket of this mass here. And that's what many times is seen on mammograms at alerts, where you can see that on ultrasound too. Other ultrasound images, as you know, can be used for many things. Classically, it's used for looking at the fetus. You can use it for looking at gallbladders and polyps in the gallbladders, various structures. And this happens to be liver metastases. So there are many, many uses for ultrasonography. It's an excellent test. The sensitivity and specificity of it are very high. Thermography, let's talk about thermography for a few minutes. It is the most underutilized imaging technique today for breast and for the human body. simply a camera which takes pictures of the infrared spectrum rather than the visual spectrum. There's no squeezing, no cancer-causing X-rays, nothing touches the skin. Again, the sensitivity is really high, up around 90%. It can also detect inflammatory cancer, which MRIs and mammograms and ultrasounds do not detect. And it can also be repeated as often as you desire. So there's what a thermographic camera would look like, an infrared camera. Nothing touches the person and it creates the image. So that's what that looks. Here is an image of a thermogram. The interpreter is looking for different things. Estrogen effects. You can see that every color represents a temperature. So in this, the red is the hottest. On this particular picture, white is the hottest in most of them. Red, and then yellow, and then green, and then blue, and then black is your coldest. So if you just look at these two breasts, you can see that the right breast is hotter than the left breast because it has more yellows and reds in it. So this breast is more suspicious than this breast. So we take and measure the temperatures of the areolas and the temperatures of the local breast and compare them to each other. Look at those, and then we can assess the risk factor as well as any specific areas that might be hotter than the others, and have a pretty good idea of the probability of whether something is going on in that breast. Now, can ultrasound detect cancer? Can mammograms detect cancer? Can thermography detect cancer? By themselves alone, the answer to that is always no. You can be 99% sure, but it takes a piece of tissue to make an absolute diagnosis. We can talk about biopsies sometime. I call biopsies the kiss of death. Put needles through there, spread the cancer. So I would rather take it out personally. If a patient comes to me without a biopsy, I'm going to leave that alone and treat that, make that tumor go away without ever spreading these cancer cells. So that's what a thermogram looks like. Here's one of Dr. Galco's pictures. She does incredible work with those. This is a lady actually from Moscow that I had the opportunity of participating in the treatment. I don't think there's any doubt about the inflammation of lymphatic congestion. That's what we look for on thermograms. Thermograms can't see cancer, they can see inflammation. That's hot. That's because the cancer underneath there, this was biopsy-proven cancer, it's causing heat. It has recruited blood vessels. It has more blood flow. Cells in there are dying, producing nitrous oxide, dilating the skin above it. So this creates a heat signature that we can see. And inflammation, you see all this lymphatic drainage, draining down into the limbs, draining up into the limbs. That's inflammation and lymphatic congestion, two of the primary causes of breast cancer, two of the primary causes of cancer, period. You can use thermography for other things. This lady is pregnant, and that is estrogen, dramatic estrogen. Here's another breast cancer patient, and I wanted this because of art in front of you. This lady has some dysbiosis going on in the bowel. So you can see other issues with thermography other than just breast. This lady has advanced sarcoma. You can see a brain in the breast here. This lady actually had a good outcome. Now we can not only use thermography to detect breast cancer issues now and coming, we can also use it to watch cancer going. If you look at the timeline, this is the 3rd, March 16th of 12. This is with progressive treatment with extreme alkaline diet, extreme alkaline foods, and insulin-potentiated therapy with low-dose chemo. And so this lady, in a matter of 8 weeks, went from here to here. She subsequently had, she just couldn't leave it alone, had a surgeon take that out, but there was no cancer in the cervical specimen. So that's how you can use tomography for detection, for early detection. We'll talk about what early detection is. So here's what those pictures look like side by side. So here's marked cancer in the breast on tomography. Here's the ultrasound picture. Here you can see the mass. And here's the blood flow. You can do Doppler on that with the ultrasound, and you see all the extra blood flow that is required to sustain that rapidly growing mass in the breast. So now you combine the two, and voila, you've got something magical. 96% sensitivity and 98% specificity. Those are amazing numbers, people. For a medical test, you just don't get that kind of sensitivity and specificity. Just so you know, sensitivity is whether it's there, and specificity is what it is, whether you're calling it what it is. Say cancer, and that's what it was. Now, why do we need ultrasounds and thermograms? Well, because we're doing a much inferior test on women today. And if you as a woman go to your traditional medical doctor today, this is what they will try to cram down your throat and smash it on your breast. They will virtually demand, castigate, humiliate you, and in every way try to get you to go do this test. It's called mammograms. The sensitivity is only 52 to 76%. Both, and even at the best, below either one of the other tests alone. Okay? The difference being accounted for, the younger you are, the less sensitive. So a 40-year-old woman, her breasts are more dense, so she could be down here toward the 50%. So those are terrible numbers that mammography produces, sensitivity-wise. Not a good test by any standards. So who are they recommending these for? Women from 30 to 100. Sensitivity for women under 49, down around 50%. Specificity, here's how specific it is. For 95% of the women who are positive on screening mammograms, they do not have breast cancer. That's a terrible test. Pathetic. Okay? How did this happen? Well, was Will Rogers said there are lies, damn lies, and statistics? Well, this was statistics. We did this by statistics. There were people receiving money from Siemens and GE who did some tests, a two-county trial and a New York trial, which showed this amazing save rate for women who were getting mammograms that they died over 30% less often of breast cancer. Well, remember, this is lies, damn lies, and statistics. The problem was women forgot to go die. So if you looked at the overall death rate in New York and the two counties in Sweden, women were still dying at the same rate. They were just dying of congestive heart failure from the chemo, or sarcoma, or osteosarcoma, bone cancer from the radiation. They were still dying at the same rate. They just didn't die of breast cancer. So they weren't counted on the breast cancer death rate. And if they died during the studies, they weren't counted at all because they didn't finish the study. So nice way to skew statistics, huh? So that's how we got here, was this promotion by the companies selling these machines to promote this whole thing. We've known for years that it's not a good test. So hopefully we read that on the move right on. So how did this happen? Hospitals paid $500,000 for these big mammograms. They want their money back. And if they do enough mammograms, you've got a built-in clientele. There are groups like Susan G. Komen out there promoting it. The American College of Radiology. You think they get any benefit from you doing a mammogram? They get to read the mammograms, they get the fee. Susan G. Komen, do you think Siemens or GE sends any money to them to promote mammograms all day long? Now, there are groups that I'm proud of. The American College of Physicians, the U.S. Preventative Task Force, recommended against routine mammogram screening. So you do enough mammograms, and what do you get? You get breast cancer patients. So it's good for business, right? It's good for the bottom line. So the routine practice of taking 4 films gives you approximately 1,000 times the radiation dose of a single X-ray. I want to know who in here is going to volunteer to stand in front of an X-ray machine and hit the button 1,000 times. Any volunteers? Well, if you've ever had a mammogram, that's just what you did. 1,000 doses of a normal chest X-ray. Didn't tell you that, did they? They actually did at the bottom with a little print that you couldn't read, that you needed a magnifying glass to read. They actually did. It gets worse. The premenopausal breast is much more sensitive, and somewhere between a 1% and a 5% increase in risk of breast cancer every time you get a mammogram. Now, this is cumulative, folks. This isn't, oh, you had it, and for 6 months you got an increased risk, and that goes away. This is the rest of your life. So you've had 10 mammograms, you have a 10% increase every year for the rest of your life of getting breast cancer. Canadian study, let's back up just a second. 1992, these started coming. We've known since 1992 that women were not receiving benefits. That is an amazing statement. Women under 35, mammography was causing 75 cases of breast cancer for every 15 that it identified. So now we've got 90 cases of breast cancer. It identified 15 and gave 75 women breast cancer. Nobody's been treated yet. Nobody's been cured. But we've gotten 75 cases of breast cancer from mammograms, and it detected 15 conditions. Okay. This is not good. October 92, they published a Canadian study showing that they had a 52% increase in breast cancer deaths among young women. Canadian Journal of Medicine, I believe, has studies not hard to find. You should be able to find that on PubMed, and the date was October 92. Of course, the big guns poo-pooed it because these were family doctors that did this study. We can't have family doctors speaking out authoritatively against mammograms. Money, power, politics, that's why this is. Again, in 92, there is an excess breast cancer mortality in women exposed to mammograms from 40 to 49, and they saw no significant benefits. We've known since 92 these were no benefit. And then in 99, the Swedes published mammography is ineffective. That was their conclusion. The Danes across the ocean from the Swedes wanted to give their women all this health benefit, so they commissioned the Nordic Conference Center, which is the think tank, number crunching group in the world, and their conclusion was the scientific basis for mammography screening is very uncertain. We cannot conclude the possibility that screening does more harm. Good. Then they came out in the next year in Lancet. There's no decrease in mortality. Screening mammography is unjustified, and mammograms cause a 4% increase in mortality. That's another word for death. Mammograms cause you to die 4% more often. If I had a 4% chance of dying if I left this hotel today, I would stay right here in the hotel all day long. Okay? And as late as last year, the Royal Society of Medicine in London, our data shows that there's no evidence of a positive effect of mammography screening for breast cancer mortality at the population level over an observed period of 40 years. Okay? Peter Gaskey wrote this book because he was the head statistician for the conference center. And here was Peter's conclusion. Scientists are often, you wonder why these doctors do this. Here's his thoughts on it. Scientists are often driven by emotions, career aspirations, strong beliefs, money, fame, rather than facts and logic. When it comes to mammographic screening, the extent to which some scientists are ready to deny what they see and sacrifice sound judgment is simply astounding. Joseph Goebbels said this, and it bears truth. If you tell a lie big enough and keep repeating it, people will eventually come to believe it. What does that have to do with this? Well, here's the lie. Early detection saves lives. Well, that's actually not a lie, that's the truth. Early detection does save lives. And then they connect it with, get your mammogram today. The problem is mammography is not early detection. You need to have about a centimeter tumor, that's about 1 billion cells, that's too late. So mammograms are not early detection. What has become crystal clear is that mammography is not the screening device that detects breast cancer. It changed the outcome, and worse, it has become part of the problem, increasing a woman's chance of breast cancer, morbidity, and mortality. So, ladies and gentlemen, I leave with you the better of the test, thermography and ultrasonography. This is what women should be doing today. 96%, 98% sensitivity and specificity, as opposed to 50 to 70%. No radiation. So these are the tests that women should be doing today. You should be doing. Thank you so very much.
And thank you very much.
Yeah, I'll be at booth 101 if you need to speak with me later or are interested in thermography and how to get that into your practice. If you're a physician, naturopath, chiropractor, whatever, nutritionist, you should have this in your office. I'll be in 101.
Dr. Johnson, I really appreciate your remarks. I wish we had more time because I know there are other things that you have to tell and integrate with not only that but also your psychology background. And the interesting anecdote to what you were talking about on thermography and mammogram. You talked at the conference in Northern California a couple months ago, and I pointed out that mammograms don't detect early cancer, but they will cause cancer. And there was a young gal, a nurse or something at Stanford, and she was highly offended. All the mammograms save lives, and I want to say save lives for the people who make money off them. But anyway, buy these tape, the DVDs, buy the CDs, share this information with your friends, family, and particularly ladies, with your husbands, to understand that the mammogram is not what you need. Harold, I think we're just about ready to go. Good afternoon, ladies and gentlemen. Certainly happy to have you here at the 42nd Annual Cancer Control Society Convention, Labor Day weekend 2014. From the earliest times in medicine over 2,000 years ago, heat has been a protocol for alleviating disease. Our next speaker has learned how to use heat and also do it legally in the United States, a combination of heat and low-dose radiation. And Dr. Cyrus Raftery, very happy to have you here and look forward to your comment. Thank you.
Agenda for my meeting, I'm going to briefly describe what hyperthermia is, what the history, the treatment sites, and I'll show you some of the recent cases we have treated in our clinic in Los Angeles. Then briefly, I review literature related to hyperthermia and biological effects of hyperthermia. Hyperthermia is, or thermal therapy is a non-invasive FDA-approved cancer treatment that raises tumor temperature to about almost 7 to 110 degrees Fahrenheit. Temperature similar to high-grade fever, except that this is localized. The first person that used hyperthermia to combat cancer was a physician, Dr. Coley. He observed that some cancer patients, when they have high-grade fever, the tumor seems to be spontaneously disappear. Based on his observation, he mixed 3 different bacteria, and he would inject the patient with this mixture, or he would directly inject the tumor sites. He reported success. He reported that he was able to extend the life of some of the patients, and in some cases, the tumor completely disappeared. My reading shows that he was more successful with lymphomas. In our clinic, we are using an advanced hyperthermia device made by Labthermix called Sonotherm. This device is FDA approved for primary tumors or recurrent tumors. This device uses ultrasound for heating. At the frequency of 1 megahertz, penetrates about 4 centimeters, sort of like about 2 inches. At frequency of 3.5 megahertz, penetrates about 10 cm, considering 2 cm of subcutaneous fat. There is no loss of energy in subcutaneous fat. The applicator head that you see here is a smaller applicator head. It has 4 ultrasound transducer, and each one of them is powered by a separate generator. So we can match the shape of heating, the shape of tumor. We have a larger applicator for chest wall that has 16 applicators. Also, we have a 16-channel thermometry unit that can monitor the temperature during the treatment. There are no long-term or short-term side effects associated with hyperthermia. The only thing we see in our clinic are some small blisters that we have to take pictures of it and magnify it to see if they in fact were blisters. And so I have magnified this picture to get this picture, and here is the blister. Some researchers have reported fat necrosis, which also resolved by itself in less than 6 months. We can treat almost any part of the body, any anatomical site, with the exception of brain and lungs. Ultrasound cannot penetrate the skull and also cannot heat lungs because these are air cavities. Ultrasound does not move in the air cavities. Now I'm going to go over some of the recent cases that we have treated. By recent, I mean the last year and a half. The first case is a gentleman, very nice gentleman, 79 years old. He had 12 years of experience with melanoma, and recently the melanoma had metastasized to his eyelid. They did surgery, the tumor recurred. They put him on a chemotherapy consisting of IP1, IP and PD1. These are the most advanced immunotherapy drugs for melanoma, in addition to Avastin. Tumor continued to grow while the patient was getting this treatment. These are some of the 3D generated images from the treatment planning CT. As you can see, the tumor is huge in the right eye. This is the tumor. Some other images, reconstructed images, again tumor. And in this image, I think you can see the extent of tumor very nicely. When he came to us, the tumor was big, fungating, smelly, and it was bleeding. After we treated him with a course of radiation therapy plus hyperthermia, he came back for his first follow-up visit, and the tumor was gone. Some pictures taken later. This shows the extent of the inflammation, and you see how happy it is. How happy he is with the result. I was invited to his house for his 80th birthday. The whole family was there. His friends were there. They were very happy especially because he was told that he has only 6 months to live. The second case is another melanoma. This is one of the older cases. The patient had developed tumor near his earlobe, and it was treated with a combination of radiation therapy and chemo and hyperthermia. You see the tumor nicely resolved. Third case is a 78-year-old Iranian gentleman with an unknown primary, but the tumor was in his lungs and metastasis to his shoulder area. Let's show you some pictures. This is a picture of the tumor. Here you can appreciate the size of the tumor, and this is the 3D reconstruction of the tumor area. And you can see this is the treatment area, the red area, the extent of the tumor. We treated him with a course of hyperthermia plus radiation. Within 2 weeks, tumors start showing signs of regression, and 2 weeks after the completion of treatment, both sides of the neck look the same. Very nice result. This is my favorite case. This gentleman, 75-year young gentleman. He was playing soccer before he was diagnosed with prostate cancer, and after completing his treatment, he is continuing to play soccer. He was diagnosed with PSA of 14.3. He was telling us that he goes to the bathroom 4 or 5 times every night. We treated him with this gentleman with a course of hyperthermia plus radiation, some of the CT images. And this is the 3D reconstruction. This is the prostate, bladder, and rectum. So we treated him with a course of hyperthermia plus radiation. His PSA dropped very rapidly during the treatment, from 40.3 to 2. He does not wake up anymore at night. If he does, it's only one time. Our last case is a 65-year-old gentleman. He was diagnosed with laryngeal cancer. He went to all of the major universities and cancer centers. They all told him exactly the same thing. You need to do laryngectomy, neck dissection, plus transplant, maybe followed with radiation plus chemotherapy. He said, I'd rather die. He came to us. These are 3D reconstruction of the radiation treatment area. And this is the treatment area from here to here. We treated him with a course of chemotherapy plus radiation. Within 2 weeks, he showed signs of progress. And then we followed with a course of radiation therapy plus hyperthermia. Even on Yelp, I wrote this. My ENT doctor did a scope through my mouth and nose and took pictures. She said that the tumor is now completely gone. I saw him 2 months ago in the clinic. He looked very healthy, he gave me a hug, he was a very happy man. Not only we get very good results, there are a lot of researchers that published their results in scientific journal, peer-reviewed journals. These are some of these are randomized studies, some of them prospective studies. Dr. Vazgani reported on 83 patients, on 44 patients for head and neck cancers. The group that received hyperthermia, they received only radiation had a response rate of 41%, when hyperthermia was included, the response rate jumped to 82%, almost double. Dr. Overgaard, a very well-known radiation oncologist, reported on 134 skin cancers. When radiation alone was used, the response rate was 28%. When hyperthermia was added, the response jumped to 46%. Dr. Issel from Germany reported on 341 patients with skin cancer. When radiation alone was used, the response rate was 13%. Hyperthermia added was 29%. This is very interesting study. It's a 10 years disease-free survival for bladder cancer. The group that received mitomycin had a 10 years disease-free survival of 15%. Hyperthermia was added, jumped to 53%, 3 times as much. Based on this data, every bladder cancer should receive hyperthermia. The last one I'm going to review is cervical cancer. Dr. Van der Zee from Holland reported on 114 patients, the group that received radiation alone had a 57% response rate. The group that received combination therapy had 83% response rate. Based on this study in Holland right now, all hyperthermia is a standard part of treatment for cervical cancer. This is survival rate, survival curve for head and neck cancer by Vazgani reported. He reported in 5 years overall survival. The group that received only radiation within 54 months, all of them died. The group that received hyperthermia in addition to radiation had survived 5 years, disease-free survival of 53%. Based on that, I think, and this is my personal experience too, that head and neck cancers are very responsive to hyperthermia treatments. Hyperthermia is approved by FDA for when it is combined with radiation therapy or chemotherapy, not by itself. So we get a lot of requests for hyperthermia by itself. Most of the time we have to include either radiation or chemotherapy. So now I'm going to discuss a little bit about biology of hyperthermia. Hyperthermia takes advantage of the difference between blood vessels of the tumors versus the normal. The blood vessels in tumors are very different than the normal tissue. Number one, they're inefficient. There are less of blood vessels. There are a lot more space between the blood vessels. There are flow variation. There are shunts from one blood vessel to another blood vessel. The result of this is an environment that is low in oxygen concentration. Additionally, the tumor cells themselves have very high metabolic rate. They need more oxygen, they need more nutrients, and they put out a lot more waste products. So these tumor cells live in a very stressful environment. When we apply heat in form of hyperthermia, normal cells, normal tissue can get rid of excess heat very easily. But tumors, because of their bad blood vessels, cannot get rid of the heat. Heat tends to accumulate in the tumor area and coagulate the tissue, coagulate the protein, leading to the cancer to the cell death. We talked about direct effect of hyperthermia, now we talk about immune effect of hyperthermia on the immune system. There are a lot of applications about the effect of hyperthermia on the immune system. I'm going to talk about only one. We know that tumors are the result of unwanted changes in the DNA molecule. It is the job of the immune system to detect these cells and destroy them. But sometimes, especially in the hypoxic environment, the environment in low oxygen concentration, these cells do not express surface antigen or surface markers that can be detected by the immune system. When we heat, we increase the diameter of blood vessel, we vasodilate, so more blood reaches the tumor, with more blood, more oxygen reaches, and reverses the effect of the hypoxic environment. So now the cells are forced to express those surface antigen on the surface, so now they can hopefully be detected by the immune system. Heat shock proteins also is a very interesting subject. They were discovered in the 1960s. There are many classes of heat shock proteins, but the one that we're talking today is 70K Dalton. The main job of this heat shock protein is that to fold newly synthesized protein to its final three-dimensional shape, its active shape. So they can participate in the activity of the cell, maybe part of the cell membrane, maybe part of the mitochondria, whatever their responsibility is. When we heat, we unfold these proteins, we denature these proteins. So now heat shock proteins have to come back and renature these proteins to a point that 90% of the activities of the cell goes to renaturation of the protein, goes to synthesis of heat shock protein to reverse the effect of hyperthermia. But it gets to a point that the cell, being smart, they said this is futile, and they start the process of the programmed cell death or apoptosis. So in a way, with hyperthermia, we are sending suicide signal to the tumor cells. Hyperthermia significantly improves the result of radiation therapy treatment. As we discussed earlier, most of the tumors, let me first back up. The most important factor in the success of radiation therapy is the oxygenation of the tumor. The reason is very clear. When we radiate tumors, radiation interacts with oxygen, forms a class of highly reactive oxygen species, and this oxygen species react with DNA molecule to cause the damage. So when we apply heat, we increase the oxygen level in the tissue to make the tumors, we make the radiation a lot more effective. Some researchers have shown that hyperthermia can enhance the effect of radiation by as much as 3 times. Also, when we radiate tumors, we cause 2 types of damage, lethal damage and sublethal damage. Well, lethal damage leads to the death of the cell, but sublethal damage can be repaired. Where enzymes like DNA ligase can go up and down the DNA molecule, find the damaged area, take it out, put a new part, so that tumor cell can continue to grow. But those enzymes, such as DNA ligase, are very heat sensitive. When we apply heat, we prevent, we disable the repair mechanism of the cell for sublethal damage. So those cells can be converted to the lethal damage and die as a result of it. Also, cells, when they go through division, they go through 4 distinct phases. The first phase is mitosis. The second phase is G1 or gap. Looks like cell is not doing much. Next phase is synthesis. The cell goes through a lot of activity, synthesizing a lot of different proteins needed for cell division. Then we have another gap phase followed by mitosis. In this phase or synthesis phase, cells are not sensitive to radiation, but they are very sensitive to hyperthermia. That's one more reason we use hyperthermia in combination with radiation therapy. Hyperthermia also improves the result of chemotherapy. We discussed that how most tumor cells, especially solid tumors, are hypoxic. They are low in oxygen. So you can imagine if oxygen, which is a very small molecule, has a hard time reaching the tumor, drugs that are huge molecules have more difficult time to reach the tumor. So when we heat, we increase the diameter of blood vessels, so more blood reaches the tumor. With more blood, more drugs reaches the tumor. So in a way, using hyperthermia, we are concentrating the drug in the tumor area. Additionally, some research have shown that hyperthermia increases the permeability of the cell membrane. So more of the drugs can actually enter into the cell and cause the damage. Similar to radiation, chemotherapy can cause sublethal damage. Again, those enzymes are very heat sensitive. By applying heat, we are preventing, disabling the repair mechanism for sublethally damaged cells. In conclusion, hyperthermia is a FDA-approved cancer therapy. It's gentle, non-toxic, and well tolerated by all patients. It's covered by most insurance companies. It significantly enhances the effect of radiation and chemotherapy. The picture of our hyperthermia treatment room in Santa Monica with a gorgeous view to Santa Monica. And we are in booth 149 if you have any questions.
Thank you very much. Ladies and gentlemen, we have time for questions. Stand up and have a question for Dr. Rafi. Over here, I sound like. Yes? Question is, hyperthermia without radiation is covered by insurance?
No, most insurances do not cover it. There are some studies, they're very old studies, they do not show high level of effectiveness in comparison when you combine it with radiation.
I would like to just add to that other countries are doing studies at various levels of hyperthermia. Japanese have done a number of what they refer to as mild hyperthermia. But again, it's usually not as a standalone treatment, it's part of an integrated approach. But if a patient had IPK insulin potentiation therapy a couple of months ago, would it still make sense to get some hyperthermia?
Well, we have done some hyperthermia treatment in combination with IPT treatments. But generally, we want to deliver hyperthermia within 1 or 2 hours of the chemotherapy.
Question over here.
Yes, hyperthermia has been around for about 30 years, and it's been done at UCLA 30 years ago. Why isn't it intuitively obvious to doctors that combining it with another therapy will kill cancer more effectively?
That may be a rhetorical question. It's been around 30 years, using at UCLA, why is it well known everywhere? That may be beyond the scope of Dr. Rafi's degree to answer. But it is a good question. And I'll add to that so many of the studies of hyperthermia in the United States have been done around the colleges, universities, MD Anderson. Generally speaking, one oncologist in charge of all those studies, all been published, all been in combination with either chemotherapy or radiation. They established beyond any shadow of doubt effective, and That's where they are. You go to PubMed, look, read the studies.
You use both grading radiation at the same time, and you do one first and follow by the other.
This is the question, do you do one and then follow with the other?
Yes. You don't do both at the same time.
When it comes to chemotherapy, we do our best to do it concurrently. So patients receiving chemotherapy and we are doing hyperthermia. With radiation, obviously that's not possible. So we do it before or after, usually within 1 hour or 2. This one.
Again, Dr. Thank you so much. Ladies and gentlemen, booth 139 in the studio suites. Do 149 and stop by and see Dr. Raffi, and I know he has some wonderful staff there to help answer more of these questions and give you some specific information. Once again, I want to call your attention to doctor results, booked by Ralph Moss, lateral study at Sloan Kettering University primarily in the 70s, and you really need to read this to understand, first of all, lateral is effective, second of all, how some people in medicine don't always tell the truth. The other one, on a practical standpoint, the DMSO Handbook for Doctors by Archie Scott. He will be speaking tomorrow, so buy your book today, be ready for him to autograph it tomorrow. But again, very, very practical. Okay, Harold, we're just about ready to go. Good afternoon, ladies and gentlemen. It's a real pleasure to have Dr. Mark Blank with us. A PhD that's done a tremendous amount of research in the area of electromagnetic frequencies. I think you even worked in the U.S. Navy, special lecturer, and so your academic credentials, work experience are tremendous. We're happy to have you because electromagnetic pollution, EMF, is widely talked about, not fully well understood. So thank you very much for being here. And then, ladies and gentlemen, he will be signing his books after his talk today.
Thank you for the introduction. Every machine has its own peculiarities, and the thing is, it's a new one. When I saw my position on the program, I wasn't quite sure how I'd fit in, but it turns out that the last speaker actually gave a fair introduction to some of what I'm talking about in connection with these shock proteins. That will come later. What I want to show you first is the book that I have put together. I published a lot, but never a book, or at least I edited books, but the thing is, this was an attempt to kind of get the message out to the public. This is an area that is generally been dominated by physicists and engineers, and it's really quite technical, so that people don't really feel they're intimidated, they don't want to get to it. But the fact of the matter is that electromagnetic fields are all over the place. I mean, ever since Edison invented the light bulb, we just have been constantly bombarded by electromagnetic fields, and it's progressed not only from electric power, which powers the electric light bulb, but now we've moved up into higher frequencies, and we've got all these devices that are around. I'm sure everyone here has his own little device sitting, they're watching their little cell phones and various devices that they carry around with them. In fact, I've seen people walking, mostly young people, who along the streets with their friends, and each one is engaged with the little device, his own little device, and they're almost totally oblivious to that they're walking with. My wife and I were at a restaurant not too long ago, and at the next table was a couple having dinner, but they were each engrossed in their own little device, and they were really not paying attention to each other. And I asked the man, I said, "Excuse me, you don't mind if I ask you a question? Are you two having dinner together?" And he kind of looked at me, but that's the way things are now. So not only has it the biological reactions, which is what I talk about, but it's begun to influence our way of life to the point where there are vast changes. But let me move on. The most common device now that pretty much everyone seems to have is a cell phone. And cell phones have been characterized as perhaps the new cigarettes. Maureen Dowd of the New York Times pointed out that this is as close an analogy as she can think of as to the way in which it can be treated. It's, everybody thought cigarettes were innocuous. No, they caused a lot of pleasure. And the people who smoked them looked so very satisfying. Of course, many doctors chose according to the advertisements. And the fact of the matter is that they were dangerous, deadly, and the fact is that people ignored it. The same kinds of things are going on in connection with electromagnetic fields. It's not the cigarette companies that are doing that, but it's the industries that are associated with all these devices, including the electric power industry, which is very much involved in supplying the basics that are now coming through with not only the cell phones, which everyone is familiar with, but with smart meters, which are ways of bringing in these new electromagnetic frequencies into our homes and getting us where we are right there. The main point that I want to make, and the reason it fits in so well with this conference, is that there is a direct connection between electromagnetic fields, exposure to them, and the incidence of cancer. I said the risk of cancer, I should say. Everyone was saying you can't prove that it causes cancer. Well, the fact is that cancer takes a long time to develop. Among the fastest cancers, let's say like leukemia, doesn't appear in children until about 3 or 4 years of age, so that's a quick one. But I have a friend who died of a mesothelioma, which did not show up till 25, 30 years later. He was exposed for a 3-month period, working with asbestos, and that was the only time he came in contact with that substance. And it took that long for it to develop. So, I mean, we're dealing with changes that occur in the body over a long period of time, and they're initiated by, in this case, electromagnetic fields. And the first part about the whole thing is that we are insensitive. We do not feel it when it's happening, but the body feels it, and it reacts, and I'll have more to say about that. Electromagnetics, as I said, is a kind of esoteric subject. For most of us, it's really the province of physicists and engineers. And I have here a picture of the electromagnetic spectrum, which you see has an enormous range. It starts off with a couple frequency, which I mentioned, that's 60 hertz here in the States, but you go through radio frequency and microwave until you get to the solar, which is, by the way, light is an electromagnetic frequency. And I have a dividing line here. That's a dividing line that is considered that was developed by physicists who pointed out that above this line, the frequencies are so strong that they have enough energy to knock electrons out of atoms. And so this is ionizing. It can generate ions. And of course, we know that it's very dangerous. It's high energy ultraviolet and gamma rays and X-rays. We know what they can cause. But below that, everything is supposed to be benign. And this is a problem that we have in connection with safety, because most people feel that if you're not ionizing rings, you can just just more or less, that's it. It's kind of natural, normal, doesn't work. But the fact is that it is causing changes, and I have more to say about that. But the interesting thing about all of this is that if you look below this line, which is kind of more arbitrarily, about 130 years ago, virtually none of this was here. This part of the spectrum, yes, there's the sunlight kind of extended, and had some little bits of the spectrum down to here. And we also had down in this range, there was a frequency that was due to the natural electrical activity that results from lightning storms that occur around the Earth and are transmitted through the ionosphere. But otherwise, this was empty. But when Edison came with his light bulb and power frequency, boy, that was the beginning. And since then, it's just been growing. And it's been added. Radio, TV, FM, cell phones, Wi-Fi, smartphones, and so on. Who knows? There are all kinds of devices, and we don't know what's going to happen tomorrow because there's bound to be more. Now, one of the things about electromagnetic fields is that the EMF will interact with lots of different chemicals. Electric forces and magnetic forces are fundamental in nature. It's a lot like gravity. Gravity, we know, is around it acts on all mass. Well, electric and magnetic fields will act on all charges. And as you know, matter is made up of a lot of different particles, but electrons and protons are charged, and they will interact with these fields that are around. So it's no surprise that EMF will interact with basic chemicals that are in our body. We know that they interact with DNA, and this is one of the things that is very important because the interactions with DNA are kind of fundamental, and they cause the activation of this heat shock response, which I was mentioned in the previous talk. And that's a very fundamental response of cells, and I'll have more to say about that. But at the very bottom of the slide, you'll see that the WHO has been considering all the evidence about the detrimental effects of these interactions. And in 2002, they said that very low power frequency, the ELF, which stands for extremely low frequency, is a possible carcinogen. And they said the same thing in 2011 for radio frequency. So the World Health Organization has used the word possible. That's a big, kind of hedging factor. There was big discussion in committee as to whether it was possible or probable. But you can look at the evidence in the science itself, because the evidence has been mounting and it's quite substantial. And if you're dealing with your own life, you wouldn't want to bet on the possible part. I think it's the probable part that will influence your behavior. Now, everybody knows that the DNA is involved in the genesis of cancer in some ways, and cancer is believed to result from mutations that occur in DNA. Now, I have here a picture of a diagram of a chromosome split apart, and the DNA inside the nucleus of the cell is 2 meters long, 6 feet. And cells are pretty small. They have to pack into micron-sized nuclei to get this to fit. And the reason it fits is that the DNA, this double helix, is coiled and coiled and coiled so that it's really compacted. And one of the interesting things about these different coils is that they are different sizes. And the different sizes lead to a different susceptibility. DNA has these 2 double helices, these 2 chains, long polymers, sugar phosphate chains that are bonded together and twisted. The bonds themselves are the code. These are called bases, and every 3 bases will code for one particular amino acid. So you have one amino acid and then the second one that's joined to it. So that's the way the code works for generating the protein. But the interesting thing about this is that the bases are not just empty chemicals, they have non-localized electrons on them. The pi bonds, as they're called, are really like two layers of electrons, one on this face of these bonds, and one on the bottom. So at the top and the bottom, it's like a sandwich, where these chemicals are the contents of the sandwich, and the electron clouds are the two pieces of bread. Well, one of the nice things about these are non-localized electrons. That's what the pi electron means, which means that they're free to move. And they've been shown to move. I mean, there are a whole group of papers that came from Caltech and the Jacqueline Barton group. They've shown that you can actually get the electrons to move when you generate a voltage across them. And that means that you've got all the conditions here for an antenna. These electrons can move back and forth on this thing, and they do move back and forth on these things. And you have antennas of very different sizes. The fact is that, if you remember back in the early days of television, when the antennas went up, you had not one wire up there, but you had two wires that were set for the two different ranges of frequencies. The length of the antenna will determine what frequency or what wavelength it will react best with. And so you've got a whole range of frequencies that can react with this whole range of different sizes of coils. So I've actually written a paper which referred to the different characteristics of DNA interaction as a fractal antenna. These are devices that are now made by engineers that enable an interaction with a wide variety of frequencies. And the DNA does that. It will actually respond to a whole bunch of frequencies. Now, you think that the government is supposed to protect us and that they will operate to do things that will protect us. And things are so bad that the U.S. Department of the Interior got so mad at the FCC that controls the protective aspect of EMF in our environment, that I'll read it to you. The standards used by the FCC continue to be based on thermal heating, a criterion now 30 years out of date and inapplicable today. That just came out a couple months ago. It's obvious that the standards that are being used to determine the safety of our exposure are really not only totally out of date, but totally inadequate. They're not up to the job. They don't really measure anything. And I'll have more to say about that. Biology-based standards are possible. And the biology safety standard is really something called the cellular stress response. And this is where I tie in with the previous speaker who talked about the heat shock response. The heat shock response was the first encounter with the cellular response to external damage. When a cell was heated, it started to make these proteins. They were called heat shock proteins. And they are made, one of them was described, HSP70 was described, and we've done a lot of work with HSP70, and it's always been stimulated by electromagnetic fields. And we found that it's stimulated not only by 60 hertz, but also by radio frequency that comes from cell phones. So, and others have done many of these same kinds of experiments. In other words, not only does the cell start to make these stress proteins, which is what I'll call them, but it will make them in response to a wide variety of frequencies. And it is indicative of the cell telling you that there's something wrong that it has to fight against. It's a signal that there is harm associated with this. Even though we may not feel what the signal is, the signal is arousing this protective response in the cell that is indicative of a harmful stimulus. So if anyone tells you that there's no evidence that this stuff is harmful, the biological evidence is overwhelming. I mean, you can get me to testify that I think there's evidence things are harmful, but if you get a cell to testify, you've got the real McCoy. And that's what we have. It's been verified time and again. So there's no question that these signals are interpreted by the cell as being harmful. We've actually done experiments to show that what part actually in the DNA causes this reaction. We've been able to take a piece of DNA in the promoter of the HSP70 and attach it to a code for another protein and stimulate that other protein. Stimulate the synthesis of other proteins. So we've tied closed the loop on that. Now, I'd like to mention this particular study that was published only a couple of years ago about that was an analysis of DNA in the population in Iceland. Iceland is a unique population that is very inbred. So the genetics is pretty, I would say, uniform. But obviously people differ, but the fact is that the background is really very common. And so they can pick out very odd little bits of genes that are very rare, and they've done that. Well, they did this study on about 80 children. They analyzed the DNA, and then they analyzed the DNA of parents, the mother and the father. And this is a plot of the mutations, plotted as a function of the age of the father. And you see that the mutations increase as the father ages. This does not hold for the mother. The number, there's no correlation with the mother. And the reason is very simple. The mother, little girls are born with all their eggs intact in the ovary and what you say, protected. And they don't ripen until puberty, and then they come out one at a time. So all their lifetime, they are sitting in this ovary protected and not exposed to the outside. Males, on the other hand, of course, don't make sperm cells till puberty as well, but there are spermatocytes that are start the process of spermatogenesis, and the spermatocytes are there all the time and they are exposed. And they are subject to the radiation that's out in the environment, and this radiation will cause mutations. They'll cause damage and they'll cause mutations. So what you have is that you've got an indication that there's a background buildup of mutations as a result of just being exposed to the environment as we find it. This is not, I mean, this is what we have to live with. That's why there's always a question about when you see it. They tell women to have their children young, and there's a good reason for it. And this is a good biological reason, I think, that we can get the reason for it. The different colored dots there are interesting, because you see that the colors of autism and schizophrenia that correlate with this as well. So it's almost as if the mutations increase. As the mutations increase, the probability of getting autism and schizophrenia also increase. Now, let me go through very quickly what has happened in studies of cancers that may result in different parts of the spectrum. If you deal with power frequency, they have found that there's an increase in leukemia that occurs at very low levels of exposure. 3 to 4 milligrams is virtually nothing. The interesting recent study was done published in 2008, where we found that if there are mutations in DNA repair genes, the level at which you get an increase in the odds ratio occurs at 1.8 milligrams rather than 2.4 milligrams. You almost double the possibility when you can't repair the DNA. Alzheimer's disease has also been correlated with exposure to EMF. This was a study that was done virtually throughout Switzerland, by the distance from the power lines, and you've got a doubling of the incidence of Alzheimer's when you were within 50 meters of the power lines. And there the average exposure was about 5 to 8 milligrams. this is relatively low. Maybe the 1.8 may be close to what we might find in this room. This is much higher. The breast cancer has also been associated with exposure to these low frequency fields. And the increase in glioma is in ELF has also has added to the exposure that comes from the microwave exposure. This is a recent finding that people that the odds ratio for brain cancer that due to exposure to radio frequency increases as a result of exposure to ELF as well. So we added to that. This is something that people may not have counted on. This is about fetal exposure to EMF. Dr. Lee did a study, and his group did a study on miscarriages. And what they did is they found that exposure to electric blankets increased miscarriages. But then Lee and his team followed up, and they got the kids who were born from that. And now they're about 10 to 12 years old. And he found that there was a doubling of asthma and a doubling of obesity in these kids. So you can't, even the uterus does not protect from exposure to these fields. So that we're surrounded by this kind of thing. Now up in San Francisco, Sutro Tower broadcasts all this, all the different signals, TV and FM and so on. And people who live close to the tower, children get more cancer as a result of the living in the vicinity of these emissions. Not emissions, these are broadcasts. And this was a study done by Neil Cherry that was published in the online. But the interesting thing about this study is that when you look on the graph, this is the when you look at this graph, you'll see that at a distance of 3 kilometers, about 2 miles, you get an increase in the odds ratio of 5 to 6, which means that you are 5 to 6 times more likely to get cancer. This is children getting cancer if you live within this distance. Neil Cherry measured the intensity of the field at this point and found that it was 1,000 times lower than the safety standard. 1,000 times lower than the safety standard. So if you thought you were safe, according to the safety standard, forget about it. The safety standard doesn't measure the safety. It doesn't measure anything in connection with the biology. Now, cell phones have had studies done. There are quite a few that show that there's an increase in brain tumors. The reference that I have up there, Leon et al., is a study that really summarizes a meta-analysis. One of the basic contributors has been Hardell from Sweden. He is not in the pay of various companies, and so his studies are generally considered to be high quality, and when you measure them, they are generally considered to tell you pretty much what's going on. And he has shown that there's a very high risk ratio associated with a certain number of hours of exposure. This is in gliomas. These are the most common brain tumors that results from this kind of exposure. The last line on there of the relative risk is so much higher if you start as a teenager, and that's becoming more and more common. This one is an interesting study about salivary glands. It's a study that was done where you measure the increase in incidence of salivary gland tumors in Israel, and it followed, they introduced cell phones rather early, and so they have a fair data, and they showed that there's an increase in one kind of cancer. This is the carotid gland, and but very almost flat low increase in the submandibular gland. You may want to give you the clue. If you're below the mandible, you're protected by the bone, the parent doesn't have an effect. each carotid area, and apparently the exposure to cell phone from people in the ear gives you enough of exposure so that it shows up as an increase in carotid line. Now, all this was put together in a report, the Bioinitiative report, which was published online by a group of scientists who felt that this information would be brought to the public, and it was. And they recommended certain standards, and you see that the standards are much lower than the prevailing ones in the United States. This was, there was an updated one that was done in the peer-reviewed literature to make those critics who said that, well, this wasn't really reviewed, to make them happy it was peer-reviewed. But now there's a new Bioinitiative, and you can all access this online. The 2012 edition is out there, and it's got now, in summary, there's evidence of many health effects, many studies, many biological systems have been studied, many frequencies. The thresholds, if you're going to measure, are very low, and there are many mechanisms. I focused on the DNA, but there's leakage of the blood-brain barrier that can explain damage that can occur in the head and brain area. The effects on melatonin, which will indicate interference with the biological repair processes. And all the safety standards that are set individually for individual devices. Nobody has talked about the cumulative effect of all of it. So what can you do? This is a wish list that everybody should pay attention to. Stay away from the sources. Power off devices when you're not moving. And this, by the way, is very important for men who carry their cell phones in their pockets. There's been an increase in many studies that show decrease in fertility, decrease in all kinds of damage to sperm cells as a result of men not shutting off the device in their pocket. Power it off. Everybody's afraid of missing a call. We can call it when you can take it out of your pocket. No reason to carry it around that way. And petition, whenever you get a chance, petition for a biologically based safety net that will at least protect you to some extent and at least indicate that there is a thing. And I've got my own issues. I think Wi-Fi in schools is deadly. There's absolutely no reason why one cannot put in cables. One does not have to have Wi-Fi and expose kids all the time. And the same thing goes for smart meters. Anyway, I hope I've done a quick introduction to a very, very important topic.
Dr. Wang, thank you very much. I have essentially two parts to one question. It relates to cell phones and children. And usually about teenagers, but now less younger than teenagers. The two places where particularly young girls carry the cell phone, one is right here, and the other one is sidebar. And you found that on that.
Yes, what I mentioned, men carrying the cell phone in their pockets, the same applies to women carrying the cell phone in their bras. There's been an increase in breast cancer, in breast-related problems, girls and women carrying the cell phone.
Thank you very much for very good. Ladies and gentlemen, Dr. Blank will be at the author signing table. There's a pretty good supply of this book, so please go there on your way to or from lunch. Also, I'd like to remind you the Dr. Chandel, American Metabolic Laboratory, in the back of the room here, has a drawing. We'll have a drawing, fill out the coupon for a drawing. Later for a complementary cancer profile test. So with that, again, we will stop by and sign up for the Tijuana Clinic Store, and we will see you after lunch. Thank you very much.
Okay, well, good. I got later that actually did start. I'm gonna buy the tape anyway. Yeah. Just all radiation amount. I'm trying to move it.
Yeah. And coming to other cities, other places, and in New York, where you went there. You want to name the best? Linus Pauling was co-op. He is involved in mechanical environmental. Well, people are used to eugenics. They're calling the population.